Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more. Hey everyone, I'm the Millennial Mechanical Therapist, and today I want to talk about why specific exercise still has to be really relevant to your physical therapy or rehab regimen, regardless of what you're treating when it comes to musculoskeletal disorders and pathologies. One of the things that's coming out and really coming to light in the physical therapy research, I guess, is that a lot of the things that we've been doing, a lot of the interventions, whether it be modalities, specific types of exercise, different muscle performance parameters, things like that, we're finding that there's a lot of controversial research. Well, some of it says it works, some of it says it doesn't work, and that as we layer things, especially exercise with manual, exercise with modalities, exercise with anything else, we get that common denominator that people keep getting better, and exercise, regardless of what's performed with it, is effective. So we get this underlying message that general exercise, kind of regardless of what you do with exercise, exercise is helpful. Well, one of the scenarios that I really want to bring up right now and kind of logically think out is that a lot of folks that come in may fit into that category of untrained individuals. And a lot of research that looks at that shows that a minimal amount of exercise can procure a great amount of gain. Now, that is certainly helpful if you see a large population of those folks. If a lot of your patients do not typically partake in any type of exercise, then that's great. Give them all kinds of general exercise and they will at least get benefits in terms of their muscular performance and things like that, and just be overall healthier. However, when you get those patients that do work in exercise, whether they do curves every day, they go to Pilates, they go to something, they like to walk, they are already trained in some type of exercise. Now, are they professional athletes? Are they high level at what they do? Probably not, but that's okay. The idea that I want to get to here, logically thinking, is that these folks probably don't need general exercise prescription since they're already doing it. If general exercise was going to help with their pain, then their already daily routine performance of exercise should have cleared that up. Now, you could certainly make the argument that a person who was active prior to their injury, that's not necessarily who I'm talking about. I'm talking about somebody who has like a nagging injury, maybe a previously termed overuse injury, which we have seen may actually just be a derangement in disguise. And even if it's not, it would benefit from a specific exercise regimen to remodel that tissue or to remodel the neuroplastic pathways that are associated with the somatosensation of that tissue. When folks come in and they are still actively partaking in daily exercise, whether it be a walking program, a lifting program, cardio program, anything I mentioned before, you're going to be best off trying to give them some type of specific intervention to address their problem. A great example is trying to find that directional preference through repeated movements and see if that it is a derangement classification that the person has sitting in front of you. If that is the situation, then just have them hammer away at that specific exercise for a while they continue their general exercise, as long as it does not leave them worse. In another scenario would be, as I was talking about before, that overuse injury. You got to remodel whatever's going on in there, whether you remodel the pain science pathways or you remodel the actual tissue. However you want to think about it, you have to get that tissue and all of its relative tissues with that osteokinematic motion. So if you have an Achilles tendinopathy and it's painful to plantar flex, well, everything goes into that. The tendon, the muscle, the nerves there, not only activating it, but also sensing what's going on. You have to remodel all of those and make sure that they are ready to accept things. And one of the best ways to do that is by using specific targeted exercise at that location to help the remodeling process. Looking into mechanotransduction is a phenomenal way to associate that. While it may be a little bit pathoanatomic based, the idea behind that is very sensible, and a lot of the research by Karim Khan is great to look at. I just want to kind of briefly throw down my thoughts on that today, guys, and let me know what you're thinking. Again, whether it's specifically that mechanotransduction process that happens, or if it's remodeling that neuroplastic pathway through pain science. The point here is that a specific exercise program is certainly going to be beneficial for somebody who's already partaking in general exercise. As we always say, move your patients early, move them often. Move them to end range, because that's where the magic happens.